Hello and namaste everyone. Today we are going to talk about heaviest, longest and strongest bone in our body, femur. Femur is a long bone present in the thigh region. This bone is about 1/4 of our total height, and the fetal femoral length is measured by using USG, and it also helps to determine skeletal disorders and growth issues. It helps in transmission of weight from hip bone to tibia. It also provides attachment to various muscles and helps in locomotion. Presenting parts. Like any other long bone, it has shaft and two ends. Articulations. Femur articulates superiorly with the acetabulum of the hip bone, forming the hip joint. This is a ball and socket type of synovial joint. Inferiorly, it articulates with tibia and patella, forming knee joint, which has two components. The tibiofemoral component is a modified hinge variety of synovial joint, and the patello-femoral component is a plain synovial joint. Side determination. Side determination can be done considering following points. Superiorly, femur has a rounded head which is directed medially and articulates with the acetabulum of the hip bone. Posteriorly, there is a vertical ridge known as linea aspera. So this is the femur of the right side and this is the femur of the left side. Anatomical position. The femur is held vertically with the upper head projected superiorly and medially, slightly anteriorly like this, and the inferior condyles touch the transverse plane. So the shaft of the femur lies in an oblique line directed inferiorly and medially. Now we discuss the features of the femur in detail. Upper end has an articulating head, neck and two bony projections known as greater trochanter and lesser trochanter. The rounded head is directed superomedially and somewhat forward. It is slightly greater than the head of the humerus. The head articulates with the acetabulum of the hip bone, forming ball and socket type of synovial joint. Medially, near the center of the head, there is a pit known as fovea capitis, and there is the attachment of ligament of the head of femur. And this pit is a site of entry of blood vessels, which is a branch of obturator artery and is responsible for the supply of the blood to the femoral head. The femoral head is capped by hyaline type of cartilage, except for at the region of the fovea capitis. Neck. Neck is about 5 cm long and connects the head to the shaft, and the neck is directed inferolaterally from the head towards the shaft, and in doing so it forms an angle of about 125 degrees in adult male. This neck shaft angle, which is also known as angle of inclination, is widest at birth, which is about 150 degrees, and it gradually decreases during adolescence. The greater width of the female pelvis leads to more medial convergence towards the knee of femur, which ultimately results in lower neck shaft angle in females. This sexual dimorphism should be taken into account during the design of the gender-specific prosthetic implants. Neck shaft angle ensures the femoral shaft can swing clear of the pelvis, which lead to effective walking and also increases the range of movement at the hip joint. Deviation from the normal angle result in altered gait and increased risk of joint problem. The neck is inclined anteriorly as it passes proximally to the head. This angle of anteversion is about 10 to 15 degrees. The neck gradually expands as it reaches the shaft. The neck is also a common site for fractures, especially in elderly population with osteoporosis. The greater and lesser trochanter are projections situated near the neck shaft junction. Ridges present on the surface of the neck indicates the site of attachment of the retinacular fibers of the joint hip capsules. Anteriorly, at the neck shaft junction, between two trochanters, greater trochanter and lesser trochanter, there is a line known as intertrochanteric line. Similarly, posteriorly, in between the greater trochanter and the lesser trochanter, there is a ridge known as intertrochanteric crest. This is also present between the neck shaft junction. The capsule of the hip joint is attached along the intertrochanteric line and intertrochanteric crest. Distal to this posterior attachment, the tendon of the obturator externus is in contact with the neck. Also, to note is the bulging of the synovial membrane of the hip joint through a gap between the capsule. Numerous vascular foraminae, which are directed towards the head, are present on the anterior and posterior aspect of the neck. Vascular supply to the femoral head in adult is mainly via these foraminae, which are also known as retinacular arteries, which is the branch of medial circumflex artery. These blood vessels and intramedullary vessels running from the shaft to the neck have the tendency to rupture in cases of intracapsular fracture of the neck of femur, and avascular necrosis of the femoral head is a potential complication in such cases. On the lateral aspect of the junction of neck and shaft, a large quadrangular posterior superior projection is seen, which is known as greater trochanter. It has three surfaces: anterior surface, medial surface, and lateral surface, and two borders: superior border and posterior border. Anterior surface of the greater trochanter shows a large J-shaped rough area for the insertion of gluteus minimus. On the anterior aspect of the medial surface, there is the insertion of a common tendon of obturator internus and two gemelli. At the bottom of the surface, there is a depression known as trochanteric fossa. In this trochanteric fossa, there is the formation of trochanteric anastomosis of arteries, as well as the insertion of the obturator externus tendon. The lateral surface is quadrangular and is marked by an oblique strip for the insertion of gluteus medius. The prominent convexity of the greater trochanter forms the widest part of the hip, which is palpable. It is covered by iliotibial tract. Superior border, which has the insertion of piriformis on its medial end, continues as posterior border, which continues as the intertrochanteric crest, ends in the lesser trochanter. Lesser trochanter. It is the conical projection pointing posteromedially. It receives the insertion of iliopsoas tendon, which is the major flexor of the hip joint. Intertrochanteric line. Intertrochanteric line is present at neck-shaft junction in the anterior part, and it receives two insertions from ligament and two insertions from the muscles. The first is the capsular ligament, and the second one is the strongest ligament in our body, iliofemoral ligament, which is also known as ligament of Bigelow. And it receives two muscle insertions from vastus lateralis and vastus medialis. Intertrochanteric crest is the elevated crest which is present on the posterior part at the neck shaft junction. In the little above the middle of this intertrochanteric crest, there is a rounded elevation known as quadritubercle, where is the insertion of the quadratus femoris muscle. Lower end. It has two condyles, the medial one and the lateral one. The lateral one is the larger one. Anteriorly, two condyles are joined together, and this area bears a trochlear articular area known as patellar surface. This accommodates patella. Posteriorly, the two condyles project beyond the line of the shaft and is separated by a deep intercondylar notch or fossa. Upper end of the anterior cruciate ligament is attached on the posterior aspect of the lateral condyle along the articular margin, while the upper end of the posterior cruciate ligament is attached on the anterior aspect of the medial condyle. This attachment can be remembered with the help of a mnemonic LAMP. The articular cartilage covers the inferior and posterior aspect and helps in the articulation with tibia to form the knee joint. On a medial view of the lower end of femur, medial condyle shows a convex non-articular medial surface and a prominent convexity known as medial epicondyle. This is the most prominent part and is the site of attachment of tibial or medial collateral ligament. A prominence known as adductor tubercle is present above and behind the medial epicondyle and is continuous with the medial supracondylar line. The epiphyseal line of the lower end passes through the adductor tubercle. The medial head of the gastrocnemius arises from the posterior aspect of the medial epicondyle. Lateral condyle. Just a little behind the middle of the lateral condyle, there is the presence of an prominent convexity which is known as lateral epicondyle. There are three pits present on this lateral end behind lateral epicondyle. The upper pit is the site of attachment of the lateral head of gastrocnemius. The middle pit is the site of attachment of the fibular collateral ligament. The lower pit is the site of attachment of the popliteus tendon. The pit behind it is a groove which accommodates the popliteus tendon during the flexion of the knee joint. Shaft. Shaft is long and cylindrical part of the femur situated between the two ends. The shaft on the anterior aspect is smooth and convex. A rough vertical ridge is present on the posterior aspect, which is known as linea aspera. The cross section of the shaft is triangular and has three borders: lateral, medial and posterior border, and three surfaces: anterior surface, posterior-medial surface and posterior-lateral surface. Medial and lateral borders are rounded, and the posterior border corresponds to a strong ridge, linea aspera, which is more pronounced in the middle third of the posterior aspect of the femoral shaft. On the upper end of the shaft, this linea aspera diverges into two lines. Linea aspera has distinct medial and lateral lip. On the superior aspect, medial lips become continuous with the spiral line, and on the lateral aspect, it becomes continuous with the rough area known as gluteal tuberosity. About 1/4 fibers of the gluteus maximus gets inserted into the gluteal tuberosity. The gluteal tuberosity reaches the greater trochanter. Area between the gluteal tuberosity and the spiral line presents another surface which is known as posterior surface of the upper end of the shaft of femur. The two lips of the linea aspera on the lower end as well diverge into two ridges known as medial and lateral supracondylar lines. This leads to another triangular area present on the lower part of the femoral shaft, which is known as popliteal surface. This surface forms the upper part of the floor of the popliteal fossa. The anterior surface of the lower shaft is in contact with the suprapatellar bursa, lying deep to the quadriceps tendon. The lower half of the intertrochanteric line, along with the spiral line, medial lip of the linea aspera, and upper 1/3 of the medial supracondylar line gives origin to the vastus medialis muscle. Similarly, half of the intertrochanteric line, along with the lower part of the greater trochanter and lateral part of the gluteal tuberosity and lateral lip of the linea aspera, gives origin to the vastus lateralis muscle. Also, medial lip of the linea aspera, lateral lip of the linea aspera, and the intermediate area gives rise to the intermuscular septa, medial, lateral, and posterior respectively, which gives rise to the formation of three muscular compartments: medial, posterior, and anterior on the thigh. Anterior and lateral aspect of the two-thirds of femoral shaft gives origin to the vastus intermedius. Below the origin of the vastus intermedius, articularis genu arises from the anterior surface. Adductor magnus is inserted medial to the gluteal tuberosity, then along the medial lip of the linea aspera, as well as along the medial supracondylar line up to the adductor tubercle. Just above the adductor tubercle, a gap is present in the attachment of the adductor magnus, which is known as adductor hiatus, through which femoral vessels pass in the popliteal fossa. Between the attachment sites of the adductor magnus and vastus lateralis, the short of the head of the biceps femoris arises from the lower part of the linea aspera. Also, between the attachment site of the adductor magnus and vastus medialis, adductor longus is inserted into the middle third of the linea aspera. Ossification. Femur is the first bone to ossify after clavicle. Femur ossifies with endochondral ossification, and the primary ossification center starts at around 7th week of intrauterine life. The secondary ossification center appears at the lower end at 9th month of intrauterine life and is a medico-legal proof of maturity of the fetus. The lower end of the femur is the growing end, and the nutrient foramen is directed superiorly. This growing end unites with the shaft at around 20 years. At the upper end, secondary ossification center starts at head, greater trochanter, and lesser trochanter at 1 year, 4th year and 12 years of life. These unite at around 18 years with the shaft. The epiphysis present at the head is a type of pressure epiphysis, and the epiphysis present in the trochanters are the traction epiphysis, which is the site for muscle attachment and not responsible for joint formation as well as weight bearing. Clinical applied anatomy. Intracapsular fracture of the neck of femur leads to a vascular necrosis of the femoral head. Femoral shaft can be approached during surgery from anterior aspect by approaching vastus intermedius and incising the muscle vertically down to the bone. The shaft can also be approached from the posterolateral aspect. Coxa valga and coxa vara. Coxa valga is associated with an increase in neck shaft angle greater than 135 degrees. The cause can include congenital or acquired conditions such as cerebral palsy, genu valgum, or knock-knees. Coxa valga decreases the stability of the hip joint and increased tension on the medial aspect of the knee joint. Coxa vara is associated with a decreased femoral neck shaft angle less than 120 degrees. The cause can include congenital or acquired conditions such as juvenile idiopathic arthritis, fibrous dysplasia, rickets, etc. It can increase the stability of the hip joint but may result in waddling gait, shortened lower limb, and can affect knee alignments. So this was a brief description of femur bone. Thank you for watching. Namaste.